Welcome, everyone. I'm Dick Deming. I'm Medical Director of MercyOne Cancer Center, and I'm the founder of Above and Beyond Cancer. Welcome to our weekly cancer education series. It's brought to you in part by a grant from the Iowa Oncology Society. And tonight, my guest is Dr. Vivian Manola. Welcome, Vivian.
Thank you for having me.
Dr. Manola is a cardiologist and an expert on many different things, but we're going to talk about some of the cardiovascular risks that cancer patients may face and how to live a heart-healthy life after cancer.
That's right. Yes.
So, but before we talk about that, let's just get to know you a little bit. So,
Okay.
where are you from originally?
I'm originally from Greece.
From Greece?
Yeah.
Really? I don't think I knew that.
Yeah. I lived my life in Greece and did my medical school in Greece and just came to the US when I was 25 or so.
Whereabouts in Greece?
I'm from Athens.
Okay.
My parents are from islands, from Naxos and Lefkada. So Naxos is at the Aegean Sea, Lefkada is at Ionian Sea.
Okay.
So a lot of nice places to visit during vacation time.
Yes.
Yes.
So you grew up in the Athens area. And so at what point in your education did you decide that you wanted to be a doctor? Did you know that all along?
Yes, from a very young age.
Okay.
Like, adolescent. When I was an adolescent, I was certain.
Did you have doctors
Doctor in the
your
family?
No?
No medical background. No.
Okay.
Yeah. So yes, in Greece, the system is a little different. You have to decide and take exams to enter medical school when you are 18 years of age. So you don't have a minor and a major. You just go straight to medical school.
Right. So you have to decide pretty early.
Pretty early, yeah.
That you want to do that.
Yes.
And so then, would you say that medical education, even though you're maybe starting at a younger age and sort of kind of get college and medical school all together, is the education similar to medical education in the United States?
Yes, it is pretty similar because the extent of like book knowledge that you get and the exposure to patients is pretty equal. And we do have a lot of pathology in Greece, so pretty similar.
Okay.
Yeah, and Athens is it's a tertiary center of obviously the University of Athens, so we saw a lot. Yeah.
And then at what point did you decide that you wanted to specialize in cardiology?
In cardiology, yes. So I always liked the heart and the pathophysiology of the heart, even from the medical school years. But going into internal medicine, the first year of internal medicine, I kind of solidified the decision for cardiology.
And was that still in Greece, the internal medicine?
No, that was in the US.
In the US.
Yes. So I came initially in Boston and did some research, and then went on to the University of Connecticut and did my cardiology training. Well, my internal medicine first, then cardiology training, and then I was looking for a subspecialty. So I was intrigued by heart failure and imaging. And I was able to do a big part of imaging during my cardiology fellowship. So then I did some extra time with heart failure alone as a subspecialty.
Okay.
Yeah.
And for those who don't know, when you use the term heart failure, what does that term mean?
Yes, that's right. So heart failure is essentially a diagnosis when the heart cannot keep up with the metabolic demands of the body. And typically that would mean that the heart cannot push blood forward. And so that would be pushing back into the lungs, and you would have symptoms of shortness of breath and fluid retention, so swelling in the legs. And that can happen if a heart is weak or if a heart is stiff.
Weak or stiff. And obviously there's a number of different causes for that. And one of the cause, not the most common cause, but one of the reasons that you're our guest is that there are certain treatments for cancer, certain chemotherapy, and actually radiation, if the heart were included, that could contribute to the heart not working as good as possible.
That's right. And fortunately, there have been so many advances in cancer therapy, but unfortunately, cardiac complications is a major side effect of cancer therapy, and it can actually happen multiple years after the treatment.
Yes. And that's one of the problems with cancer treatments where the side effects might occur 5-10 years later, is that the patient may, be cured of cancer and totally not even thinking about cancer or the cancer treatment being a factor that contributes to
Correct.
heart disease down the road.
Correct. And that is actually what was happening 10 and 15 years ago.
Mhm.
People were considered cured of cancer, but then they were ending up dying from heart failure because it wasn't recognized. So because of that reason, the American College of Cardiology and the cardiology societies, along with cancer societies, have created a specialty which is called cardio-oncology, which is essentially focus on patients who have received cancer treatment to prevent toxicity by treating risk factors and follow up so that if the patient develops disease, it is treated early.
Mhm. So let's maybe talk about some of the chemotherapy drugs that are most noted to have a risk for causing cardiac toxicity or heart problems.
That's right. So anthracyclines is, of course, a therapy that is very much used, and
adriamycin is
yeah.
the red devil for those who might have received it. So it's an infusion. It's often red in color and is called adriamycin, and it's a common chemotherapy drug in many different types of cancers, but specifically breast cancer is one of the common cancers that is treated with adriamycin.
That's right. And then HER2 targeted therapies is a very big one.
Yes.
And there are multiple HER2 therapies, and nowadays there are combination HER2 therapies which give you additional risk. So adriamycin and HER2 therapy, I would say, would be one of the worst combinations for the heart.
And for those who might not know, we're talking primarily breast cancer, which is HER2. So, in those of you that have had breast cancer know that there's these markers we look at: estrogen receptor, progesterone receptor, and HER2. And if your cancer cells have an overexpression of this HER2 protein, your doctor will often recommend a treatment that is a targeted drug against HER2 positive breast cancer. And the two most common drugs are Herceptin and Perjeta. So those have the risk of cardiac toxicity.
That's right. And because of that reason, your cancer doctor will check very regularly echocardiograms if you are on HER2 therapy.
So what is an echocardiogram and how does that differ from an EKG?
Yes. So echocardiogram is an ultrasound of the heart that will show us the heart ejection fraction, which means the power of the heart, and how well a heart contracts. A normal ejection fraction ranges between 50 to 70%. The echocardiogram will also show us valvular function. So if we have any leakiness in our valves, it will measure the chambers of the heart. So it gives us information about the structure of the heart. With HER2 therapy and anthracyclines and adriamycin, what we care about is the ejection fraction, because that becomes low, and that's when we talk about systolic heart failure, which means heart failure with decreased ejection fraction.
So that's really a measure of how powerfully your heart is beating, how it contracts and functionally sends the blood forward. What does an echocardiogram consist of when a patient gets it? Is it all external? Is there any internal component? Or
yes, so usually we would go externally, and that would be called transthoracic echocardiogram. we would only go internally, and that would be called transesophageal echocardiogram if we wanted to, in patients where the body habitus does not allow us to get good pictures, or if we wanted to see some anatomic structures that are not well seen with the transthoracic. But typically for cancer patients, a transthoracic is what we
So
do.
it'd be similar to if a woman who's pregnant goes in to get an ultrasound. You
Exactly.
put some jelly in a transducer and you just rub it across the skin on the outside. But
Exactly.
obviously you're focusing on the heart.
On the heart.
So it's a non-invasive,
Non-invasive.
not painful,
Exactly.
easy procedure.
Easy procedure, yes.
How long does it take to get an echocardiogram?
It depends a little bit on your images, but it typically takes 20 minutes.
20 minutes.
For the acquisition. You need to position the patient. So the whole exam, we book approximately an hour. But yeah.
So my experience, and again, I'm a radiation oncologist, not a medical oncologist, so I don't actually prescribe the Herceptin and Perjeta, but it seems from the patients that I follow who are getting it that the medical oncologist will get an echo before they start the treatment.
Correct.
And then because the treatment often goes on for a year, every 3 months they do another echocardiogram. So is the Perjeta and Herceptin, do you sometimes recognize heart damage that early? Like 3 months into treatment, you might already be seeing some effects?
You can,
Okay.
yes. And if that was the case, then you would modify treatment. Now, we read a lot of echocardiograms, and it doesn't happen very frequently, but you are at the highest risk to develop damage within 1 year of treatment or 1 year after end of treatment. So you definitely need to be checking every 3 months and then 1 year after treatment. And then you are still at risk. So you do need to continue to follow, but you don't have to be doing echocardiograms every 3 months. And following may mean that you need to follow with a cardiac doctor once a year, and then kind of they determine when you need to do the next echocardiogram.
I'm not sure how long Herceptin's been around, but would you perceive that a patient may have to do once a year for the rest of their life?
It's not clear in the guidelines. Definitely the number that is out there is 3 years, but a visit with a cardiologist every year.
Okay. And how does Herceptin or Perjeta, the two anti-HER2, how does that drug damage the heart?
Yes. So initially, the thought process was that it was a reversible damage. But now, and we don't know exactly the mechanism, but it was thought that after the treatment is done, and if you put patients on medications, the heart function will recover fully. But then through evidence from pathology, we know that this is not true. So it damages in a molecular level that it truly is not reversible. Even if you see improvement in the ejection fraction, which you will with medications, there is some change in the molecular level that will not be reversed.
Okay. Let's go back to the anthracyclines, in particular adriamycin. So I might be mistaken about this, but it seems to me that the medical oncologists don't routinely order the echocardiograms on patients on adriamycin.
Correct. Yes.
Only if they suspect that there's a problem. Is that right?
Yes, and there is no specific protocol for the adriamycin. So once a year, I would say, for adriamycin as a common, also after they finish their treatment, before they finished, and after they finished.
Seems to me, and correct me if I'm wrong, that there's kind of a dose response and that they've actually figured out what kind of a lifetime dose of adriamycin is, that if they don't exceed a certain amount, it reduces the chance of cardiac toxicity. Is that correct?
That's right. There is a higher dose, but many times the notes to us don't come with the doses that are given. And I was under the impression that many times they do reach a dose that could be toxic. But yeah, we don't get that information most of the times when an echo order comes or when we see patients.
Yes.
Yeah.
So besides, in addition to adriamycin, Herceptin, Perjeta, are there other names of chemotherapy drugs that are noted for causing cardiac toxicity?
So the new medications are the immunomodulators,
Mhm.
and these are used more broadly in cancer, not just breast cancer, and they are medications that have very low chances of causing heart disease, but it's actually a disease that can be extremely dangerous. So they would be causing myocarditis, which is an inflammation of the heart, and that could be causing very severe and acute heart failure, which can put you in the hospital, and it would be a very severe form of heart failure.
And that typically happens while they're on the medication,
Correct.
not as a late side effect. It's rare, but when it happens, it can be severe.
Correct, and it can also lead to rhythm abnormalities. So that's I think the newest cancer therapy that.
Right. And for those who may not know, that some of the names of those immunotherapy drugs would be like Keytruda, Opdivo, Yervoy, and every drug has two different names, but those are just some of the more common names. I'm also aware that occasionally a very common drug that is used in many different types of cancers, 5-FU, can cause coronary artery issues, right?
That's right. Yes.
Like a
Coronary spasm. Yes.
that could lead to even an acute heart attack by causing some narrowing of the
Of the
coronary
arteries.
artery.
That's right. So when we talk about coronary spasm, we're not talking about the muscle of the heart, we're talking about the coronary arteries. So these are the arteries that give blood to the heart. And when we talk about having a heart attack, typically what we mean is that plaque obstructs this artery, so there is no blood flow going forward. What can happen sometimes, and it can happen with 5-FU, is that you can have coronary spasm. So it's not really a structural blockage, but it's a functional blockage because the coronary artery goes into spasm, and it can feel like a heart attack. So you will have exactly the same chest pressure going into the arm, and you will go to the hospital, and they will do a testing of your troponins, which are the enzymes that are being leaked by the muscle when it suffers, and those would be elevated. So it's relatively common, and it is also dose related.
Okay.
So if you lower the dose, or if you change from a continuous infusion to something different, then that can affect.
Okay. Any other cancer drugs that come to mind that cause cardiac toxicity?
Almost everything can
cause it, okay.
but estrogen therapy, you do need to be careful of lipid control and hypertension.
So the estrogen modulators and aromatase inhibitors. So
yeah.
like tamoxifen and anastrozole and letrozole.
That's right.
They don't affect the heart directly, but they can elevate
your risk factors. They
Okay.
can elevate your risk factors for heart disease. And with cardio-oncology, a big part of the prevention is the risk factors.
Okay. Before we get into risk factors, let's just we talked about some of the chemotherapy or the medical treatments for cancer that can contribute to heart disease. Don't want to forget about radiation.
Yeah.
So in olden days, and we're talking maybe 30 years ago, where we didn't have some of the imaging techniques and we weren't as specific on where the radiation went, and we tended to use larger fields. So I can think of two situations in particular. Young folks who had Hodgkin's disease, where we used to treat with radiation instead of chemotherapy, and the area that you treated would be all the lymph nodes in the neck, all the lymph nodes in the chest, the lymph nodes under the arm, the lymph nodes down the center of the body. And the consequence of radiation is that years after the radiation, you can end up with scar tissue, including scarring of the coronary arteries.
That's right.
So we saw a significant increase 10 years or more after the radiation of increased coronary artery disease.
Yes.
And then the other situation was left-sided breast cancer. In the early days of doing a lumpectomy and radiation, we treated much larger fields, and women whose left breast was being treated, some of the left ventricle of the heart just happened to be in the way. And so coronary artery scarring contributed to an increased risk of coronary artery disease in women with left breast cancer.
That's right. So the radiation accelerates coronary artery disease. So that plaque buildup that can happen to everyone if they have risk factors, and it happens with age, regardless, that will be accelerated when you have received radiation.
Fortunately, we now know the risk of radiation, and in Hodgkin's disease, radiation is used less frequently, and in left breast cancer, the fields are much smaller, and we intentionally do treatments that avoid the left ventricle, so it's not nearly as big of an issue.
Correct. And the other big issue that used to happen with radiation would be valvular disease. So actually the radiation would scar up the valves, and people would end up with very leaky valves. And we typically, that's with lymphoma patients who received a lot of radiation, and we don't see that anymore.
Yes.
Yeah.
Yes. Well, very good. And now let's talk about risk factors other than the chemotherapy and radiation. So we know that we have the power to modify a lot of risk factors. We've talked about a lot about how do you modify the risk factors for developing cancer. So we know that not smoking, not drinking, eating healthy, exercising, and getting vaccinated for HPV. Those are just some of the many things we can do to modify our risk of getting cancer. What are some of the things we can do to modify our risk of getting heart disease?
And it's exactly the same. Everything that you mentioned and nothing more. So heart healthy diet, daily exercise, no tobacco use, decrease stress, meditation techniques.
Yes, that's one I left out, but that's a very important one in cancer too, is stress reduction.
That's right.
Yeah, so the great news is pretty much the same things we do to reduce the risk of having cancer, reduce the risk of having heart disease, reduce the risk of having diabetes, reduce the risk of strokes, and a number of other chronic diseases.
That's right. Everything is truly connected, and it feels like a basic pattern is inflammation. A lot of these conditions will just increase inflammation in the body, and inflammation deteriorates everything. So everything that we can do to prevent inflammation and just increase antioxidation and decrease stress will prevent everything.
One risk factor that we talk about in cancer, we don't consider a modifiable risk factor, but we know that perhaps 10% of cancers are related to a genetic predisposition to cancer. So whether we're talking about the BRCA gene or we're talking about Lynch syndrome, so we know certain mutations definitely increase the risk of cancer. Do we have a knowledge of mutations, germline mutations that increase the risk of heart disease?
Yes, absolutely. The way you have panels to check for cancer mutations, we have panels to check for disease, for heart disease. And we actually have specific genes that are related to sudden cardiac death, so arrhythmias, and we have other genes that are related to a thick heart muscle, such as hypertrophic cardiomyopathy, or a weak heart muscle, such as dilated cardiomyopathy. A very common example of genes for dilated cardiomyopathy are genes that are in the titin family, so titin mutations, whereas for thick heart muscle, which is a hypertrophic cardiomyopathy, are genes in the sarcomeric mutations.
What about, do we think that there's genetic mutations that predispose to coronary artery disease?
No, we don't have that.
We don't have that.
Mm-mm.
So, and who would you test? So, for example, in cancer, if somebody has, so first degree relative, as everyone knows, means it's either your mother or your sister or your child. So if you've got 2 first degree relatives that have had breast cancer under the age of 50, that would be a clear indication that you should check for genetic mutations that might predispose for breast cancer. And
That's right.
There's different ones for others. Do you have the same sort of thing for?
Yes. So for dilated cardiomyopathy, so when the heart enlarges and becomes thin, the typical recommendation would be to check if you had a disease in 3 generations.
Okay.
In hypertrophic cardiomyopathy, because the risk of sudden cardiac death is much higher, once you see a heart that looks thick and suspicious for hypertrophic cardiomyopathy on the ultrasound, and especially if there is family history of sudden cardiac death, which can be linked to this disease, you would test for that mutation.
Okay.
So it depends a little bit on the presentation.
Gotcha.
And I did have to mention, we do not have any genes that we know that predispose to coronary artery disease, but we know that familial dyslipidemias predispose to coronary artery disease.
And that's a genetic.
And that is a genetic condition.
Gotcha.
And typically that condition means that you have such high cholesterol that it wouldn't be able to be corrected with diet. You would definitely need to be on treatment, and that treatment would typically be a statin medication, and even more so an injectable medication such as the PCSK9 inhibitors.
And when would you know that you should test someone for that genetic mutation? You need to know that your parent had dyslipidemia.
So we wouldn't be checking for the genetic mutation. We would just be checking lipid profiles.
Okay.
So it's more of a blood test.
Gotcha.
And it would be by family history.
Okay.
Typically, there is family history of premature coronary artery disease, which means a heart attack at a young age, earlier than 50 for males or 60 for females.
Okay. If someone's father died of sudden cardiac death at age 49 and no autopsy was done, would that be an indication to do testing? Or if it's presumed that it was coronary artery disease, you wouldn't, but if you thought it could be one of the other
That's right.
hypertrophic causes.
Exactly. Depends a little bit on how the patient that you have in front of you, so the offspring of that parent presents.
Okay.
But we are always very cautious about sudden cardiac death at an early age in a family member. We tend to test as much as we can.
Okay. So in the world of cancer, if someone had a genetic mutation that predisposed them to cancer, we might start screening them for cancer at an earlier age. We might even, to reduce the risk, remove some organs before cancer developed. What do you do if you test someone and they do have a genetic mutation that puts them at greater risk for developing one of the heart diseases?
Yes. So the genetic mutations the results come in 3 categories. The category that definitely determines that you have a pathogenic mutation, it's called a pathogenic mutant. And if you identify that, first of all, you will want to test the family, especially when we're dealing about hypertrophic cardiomyopathy. So we recommend that all the family, at least first-degree family members get tested. Now, when we are talking about dilated cardiomyopathy, what we would do is we would be more aggressive with risk factors, and we would choose medications to treat the risk factors that would have benefit, protective benefit for the heart muscle.
So, for example, hypertension or hyperlipidemia,
Correct.
you would be more aggressive at treating those early on.
That's right.
Trying to keep those under control.
Yes.
To reduce the risk of the heart getting worse.
Yes, and there are so many medications to treat hypertension, but there are a few of them that we also use to treat the heart muscle. So we would choose those medications that also treat the heart muscle so that you can get the dual effect.
Okay.
Yeah.
So back to modifiable risk factors for cardiac disease. So in the United States, coronary artery disease is still the number one cause of premature death in the United States, with cancer right behind number two. And fortunately, modifying our lifestyle to prevent one also can help prevent the other.
That's right. Yes.
So I would say that if we all took a written test right now on what we should eat, we'd all get an A on the written test, but we don't always succeed in the practical test of what we actually put in our mouth.
Yes.
So how do you counsel patients, and what do you think is the most successful way for trying to get all of us to do what we know is the correct thing when it comes to diet?
Yes. So I'm not sure if we would get an A in the written test.
Oh, really?
Okay. I'm not sure. I think knowledge is power, and we all know that fruits and vegetables are better than a hot dog.
Mhm.
But it's much more than that. And especially nowadays, it is very easy to confuse unhealthy food for healthy. Because there is a lot of marketing of food as being healthy, but because it may have some spinach or some vegetable in it, but it is very high in calories, and they have used a lot of carbs, and it's truly not healthy.
Okay.
So I think going back to the very basics and non-processed is a very safe bet. But and we can talk about all categories, but essentially fruits and vegetables, legumes, which a lot of us don't eat, non-refined grains would be the other one. So essentially, we don't want processed white bread, but we want to go with wheat bread. That is a very simple example. Nuts, which need to be unsalted. And then, did I mention all the categories? And fish, trying to substitute our red meat for fish and chicken. And then the things that we need to avoid would be the processed meat, especially deli meats, sodas, sweetened drinks. And that's another big one. Nowadays, we have the flavored water and carbonated drinks, right? But there are so many in the market, and you don't know, unless you pay attention, you don't know which is the healthy option, because you have options that have a lot of caffeine and a lot of sugar substitute. And then you just have some other options that have flavored water, and that's what you need to drink.
So a couple of questions. One, tell about dairy. What about dairy?
Dairy, yes.
Is dairy, can that be part of a heart healthy?
Yes. Dairy can absolutely be part of heart healthy. It should be in moderation.
Okay.
So it should definitely not be more than a few, like 4 servings a week. It used to be thought that non-fat dairy is better, but there is research showing that even full-fat dairy, so full-fat yogurt, would be okay. The other thing about dairy is that, for example, soft cheeses and yogurt, which is what is typically used in the Mediterranean diet, is much better than hard cheeses.
Okay.
So not all dairy is the same. And also what will dairy substitute, right? So if dairy, and that's a big problem with research in nutrition, because there are some research trials showing that a low fat diet is good, and some research trials that show that a low fat diet is bad. And the reason for that is that you substitute with different things. So if you're going to substitute with a lot of carbs and a lot of processed meat, then you're gonna get less benefit than if you substitute it with olive oil, nuts, and legumes.
Mhm.
But yes, for dairy.
Okay. And we can talk about Mediterranean diet. You're obviously
Mhm.
grew up in Greece, right
That's
there.
right. That right there.
Parents grew up on islands right in the
Yeah.
middle of the Mediterranean. Tell me about olive oil. Can anyone eat too much olive oil?
The answer is no.
Really? Okay.
No.
More, some is good, more is better.
Yeah.
That's kind of what I've.
Yes. So the basis of the Mediterranean diet is olive oil, but the reason for that is that you get your fat from olive oil. So when you do a lot of olive oil, it's because you don't do too much fat otherwise.
Right. So you're putting olive oil on your bread instead of butter.
That's right. You don't do butter. Butter is bad. You put olive oil in your bread. You cook foods with olive oil. So,
Mhm.
for example, a Greek food that I grew up with, we boil olive oils. I'm sorry, we boil legumes, and we put olive oil in the food for taste and for calories.
Mhm.
Or we would boil our green beans, and we would do the same, a big amount of olive oil. We would have a very big green salad with a lot of olive oil.
Mhm. So olive oil on everything.
Olive oil on everything.
Yes.
And actually, there is research that shows that that's why the Mediterranean diet has been easier to follow long term, because it's sustainable to get your fat from olive oil and nuts rather than trying to do completely low fat.
Mhm.
One more
Mhm.
comment on the olive oil. It really needs to be extra virgin olive oil, which is completely different than canola oil or vegetable oil.
Right. And so that's the first pressing of the olives.
That's
and
right.
It's a monosaturated fat,
Fats.
right?
That's
And-
right. And it also has all the antioxidants that other olive oils are missing.
Okay. So I'm going to fess up that I'm trying to eat healthier and trying to do more vegetable based, but I want to get protein. So the first time ever this last week, I bought tofu.
Okay.
So I like legumes, and I had lentils with olive oil and some vegetables, but I'm thinking I want to make sure I have enough protein. So what do you think of tofu?
Yeah, tofu. The Mediterranean diet does not have much
Does not
tofu.
have. Mhm.
Tofu is essentially a soy-based product. Soy is considered to be a good product, and it is a source essentially of carbohydrates. And you need carbohydrates in your diet. So carbohydrates is not a no. But you need to try to find the good carbohydrates. And those are carbohydrates that have low glycemic index, which means that they are not going to raise your blood sugar, blood glucose very high after you consume them. And soy is one of them.
Mhm.
So
But
yes,
doesn't
for
tofu also have a lot of protein?
Yes, and it does have a lot of
Okay.
protein. Yes.
So one of the questions I have, so I know that we're not supposed to eat highly processed foods, and I know that this is from soybeans, but this brick looks like it's highly processed.
Yes, and
So does it end up going into the bad category because it's highly processed, as opposed to I should just be eating raw soybeans?
yes. So, and that's the bad thing about soy. Uh, and that is why it is not 100% that it is healthy, because it is so processed. So if you were able to find a non-processed source of soy, it would be
So
all benefit.
edamame, just the beans.
That's right,
Would
just
be a
a
healthier
healthier
choice
choice.
because something happens when they process that into this brick.
That's right. But it is still not considered a bad choice. I think if you eat it in moderation, it is a good source of protein. However, I would say a better source of protein would be fish.
Fish. But egg whites.
And egg whites. Eggs are absolutely fine.
What do you think about the yolks?
The yolks, eggs have been accused of increasing cholesterol, but the research now shows that even though they increase cholesterol, they are not linked to cardiovascular disease.
Okay.
So it's a good type of cholesterol that they increase.
Good.
Yeah. So good for, and fish more than 2 to 3 times a week.
Okay. I think we're going to open up for questions because now I'm getting into questions with you that I think the audience would like to ask about as well. So anything you want to know about reducing your risk of cardiovascular disease or anything about the relationship between your cancer treatment and heart disease?
Someone that had breast cancer treatment had adriamycin. Do they need something from their oncologist or from their radiologist if they had radiation also to come and see you, a referral, or can they just call your office?
They can just walk in. Absolutely, yes. It is a risk factor.
So patients can refer themselves for a cardiology evaluation if they're concerned that they received a form of treatment that might have caused heart disease.
Correct. Yes.
Okay.
Got some questions coming in. A viewer on YouTube, Stacy, wants to know, can you ask if Rituxan causes heart issues in some lymphoma patients?
Rituximab.
Yes, rituximab.
In some lymphoma patients. So everything can cause cancer disease, but rituximab is not one of the ones that are high risk for cardiotoxicity. So typically, when there is something that is not a common offender, I will go in the literature and see. I have not personally seen anyone that had cardiotoxicity with rituximab, and I'm not aware of it being a common side effect.
Okay, good.
And here's an interesting one. Does SLL/CLL run in Greek families?
Sickle cell?
Chronic lymphocytic leukemia, CLL,
Okay.
or small cell lymphocytic leukemia.
So it's not to my knowledge.
Okay.
Yeah.
So we must have a Greek friend
Yeah.
calling in. So are there any particular diseases that have a higher incidence in the Greek population than
Sickle cell disease.
Sickle cell. Okay.
Disease. And there would be also a type of cardiomyopathy that can cause sudden cardiac death, which is called arrhythmogenic right ventricular cardiomyopathy.
Okay.
So, but none of those are related to, yes.
And then there's a problem with the Achilles tendon. Yeah. Yeah, that runs in Greeks. I'm joking. That's right. Yes. Achilles, yes.
So another question, just over the past years, maybe decades, are some of the risk factors, have they been found to have been overestimated as far as their significance is concerned? And I'm thinking about maybe things like salt, maybe the effectiveness of aspirin. And then I think about maybe not emphasized enough, maybe the big gorilla in the room, stress.
Mm-hmm. Yes, I mean, salt is definitely a risk factor for cardiovascular disease and cardiovascular mortality, and for hypertension. The Western diet has a lot of salt, so a very big part of the dietary modifications that we discuss in our clinic is low salt diet, and we talk about a restriction of 2,000 milligrams, which, if you think about it, it is still a lot of salt. But essentially, we start like that because in the Western diet, we may even be consuming double that, and we are not even realizing. So we talk about reading labels, and decreasing the amount of processed foods, because that's where most of the salt will come from. Most of the patients come back after starting to read labels, and they say, I cannot believe how much salt I was consuming. I mean, we get that from almost everyone who starts reading the labels. Stress is a big one, of course. I mean, there is research showing that there is more heart attack, more stroke with stress. And that's why we do promote, meditation and relaxation techniques.
And what about a baby aspirin? Who should take a baby aspirin every day?
There is a huge debate about baby aspirin. So we used to recommend baby aspirin in everyone who has hypertension, and that is not the recommendation anymore. So truly, baby aspirin is for people who have either coronary artery disease, so a prior myocardial infarction, or a lot of risk factors for coronary artery disease we may consider. So coronary artery disease or any other atherosclerotic disease. So that could be disease in the legs, disease in the carotid arteries, anywhere where you have plaque in the body, you would benefit from aspirin. Okay. And nowadays, a way to identify early disease, and that would be something that we would do if we wanted to be very comprehensive. If someone had risk factors for coronary artery disease, we would check their coronary calcium score. So that is a CAT scan that tells you how much calcium you have in the arteries, and can be checked in young people that have risk factors. So you don't have to have any clinical disease or any clinical symptom. And if we see that you are in a higher percentile than your peers, because that's how the result will come to you, that you are at the 70th percentile compared to people who are of the same age to you in race, and sex, then we would recommend an aspirin and possibly a statin.
And last question, maybe this is in the category of mental health, but particularly post-cancer. What about just attitude, morale, the will to live, positive thinking? How important is that? And can that have a physical effect on heart function?
Yes, I don't know that has been studied. I also don't know how easy it would be to study, but I think we all see it in our daily practice that people who are positive do better, just have better outcomes. So
maybe a follow-up to that question, dying of a broken heart. So individuals who lose a spouse.
That's right, yes.
They have a statistically significantly higher chance of cardiac death in the next year.
Yes, correct. And, who knows why that is. I mean, that could be because they got depressed, and that is a risk factor, and they became sedentary. But we do see it very frequently. We see it a lot of acute events after a big adverse event in the family. And there is actually a form of cardiomyopathy that happens, and it is stress induced. So the heart gets weak acutely after a very big stressor. We call that stress-induced cardiomyopathy. And typically, it is very easily and quickly reversible once the patient calms down. And yeah. I did want to talk a little bit about, because I didn't answer the question about how difficult is it to do everything that needs to be done.
Yes.
And it is very difficult because we have no one helping us. We have marketing that tells us to eat otherwise. We have lack of time. We have lack of resources many times. There are many places where you cannot get to good food very quickly. Price is an issue. There is research shown that healthy diet is approximately $500 more expensive per year than unhealthy diet. So we have a lot of obstacles, and we don't have educational programs to support healthy living. No one is really trying to get us to eat healthy.
Mhm.
So you really need to be very aware and try to arm yourself with knowledge and persevere to follow healthy living and healthy eating, because it will just not happen otherwise.
Yes. Other questions? Yes, Sherry.
You touched upon it a little bit about when your heart gets sad. I think I've heard of it as broken heart syndrome.
Mhm. Yes.
And what physically happens to your heart when a sadness brings on that issue?
Yes. So what we hypothesize is happening is an urge of adrenaline that shocks the heart and shocks the cardiac cell. We know that one of the mechanisms of heart failure, one of the multiple mechanisms, is an adrenaline-driven mechanism. So more adrenaline than what you need. So, and when we're talking about adrenaline, essentially what that is the sympathetic nerves in our system. So our body has sympathetic nerves, which cause that adrenaline rush, and parasympathetic nerves, which are the ones that helps us calm down. And in heart failure, and specifically stress-induced cardiomyopathy, that sympathetic nerve system just goes crazy. And that's what shocks the heart.
Right. And that's the fight or flight.
That's right, the fight or flight response. Yes.
Mhm. Yes.
Do you find that if 8 hours of sleep is better for a person and their risk is lower for a heart attack or
Yes.
heart problems?
Yes. Sleep is very important. People who sleep well tend to have better health. A big risk factor for multiple heart conditions is sleep apnea. So not exactly the same as sleep, but a very important condition that is not identified as much as it should be. So sleep apnea is very common. It increases your risk for hypertension, high blood pressure, arrhythmias such as atrial fibrillation, and heart failure, and needs to be treated with tested with a sleep study and treated with a machine. In terms of quality of sleep, I am not aware of data, but we do see it in our clinics that it does make a difference.
I'd like to talk a little bit about alcohol and in particular red wine. So back when I trained in medical school 40 some years ago, we were taught that some alcohol made you healthier than no alcohol. I think the data now suggests that there isn't a safe amount of alcohol. But I would
Debatable.
Okay, debatable, still debatable. And then so what about red wine?
Yeah.
You know, there we were talking, oh, red wine's good for the heart, and that's the reason that you know, there's so many centenarians and Sardinia and different parts of the Mediterranean. But now I'm reading data that there was potentially some flaws to that data, and that perhaps no alcohol is better than some alcohol.
Yeah, so that's the difficult part about nutrition research, that there are so many other factors that affect, and it's just a little bit difficult to make conclusions. So that is the case with dairy, that is the case with carbohydrates, and also that's the case with saturated fats. So there is still some question there, and that is also the case with alcohol. So when you don't have strong data, what you suggest is with moderation. So some guidelines still say that it is okay to consume 1 glass of red wine for women and 1 to 2 glasses of red wine for men daily.
Okay, not
And
per
that-
meal.
Not per meal,
I'm
and
kidding.
that would be a small glass.
Yes.
And that would be red wine. It wouldn't be hard liquor. However, we still do see that, for example, atrial fibrillation, which is an atrial arrhythmia, many times alcohol will be a trigger for that.
Mm.
Or when we do have someone who has a cardiomyopathy, has a weak heart, because alcohol can be a toxin, we will generally advise no alcohol until we strengthen the heart.
Gotcha. The cancer data is looking more and more that there is no difference between hard liquor, beer, and wine, that alcohol is alcohol,
Okay.
and that any amount of alcohol increases the risk of cancer. That's kind of the current consensus, but there's
It
still
is
differences of
difference,
opinion
yeah.
about that.
And then what about coffee? I think coffee is another big question.
In the world of cancer, coffee is good for you.
Coffee is good, yeah.
There's no data that drinking coffee increases the risk of cancer at all.
Okay.
In fact, there's some data it reduces the risk of colorectal cancer. There was maybe 20 years ago there was a paper that was trying to link that suggested perhaps coffee and pancreas cancer. That's been totally disproven. So there's no cancer that increases due to the consumption of coffee.
Okay. In terms of cardiovascular data, 3 to 5 cups of coffee is the gold standard. And there is some research showing that more than 5 cups could be linked to cardiovascular side effects.
Okay.
Yeah.
Great.
Mhm.
So thank you. That hour is up, and we're going to have you back. This was wonderful. So thank you.
Thank you.
Dr. Vivian Manola, Izue Ine Orea.
Oh, ευχαριστώ
So I
πολύ.
think I tried to say life is beautiful in Greek.
Yes.
Kalispera.
Kalispera.
Good evening. And if any of you know someone that would benefit by watching this program, it will be available on demand on the Above and Beyond Cancer YouTube channel and the MercyOne Cancer Center website tomorrow. So I hope you will join us again next week for our cancer education series. Thanks for coming.